All right, now we're going to talk about magnesium and calcium. And the first thing I want you to write at the top of your page is this. They act like sedatives. They act like sedatives. And everybody in here knows how a sedative makes you feel. And in textbooks, they'll use the term central nervous system depressant. We don't have time for all those words. We're going to say sedative, okay? All right. Now, one fact. Magnesium is excreted by the kidneys, and it can be lost other ways too, like the GI tract. All right? Now, I want you to focus on the part that says magnesium is excreted by the kidneys for right now. Hypermagnesemia causes renal failure. Well, that's easy. If your kidneys aren't working, are you getting rid of any magnesium? No, you're not. So it's building up in your bloodstream. And then antacids can have a lot of magnesium as well. Okay? But normally, if you have good kidney function, you're still going to be able to excrete the excess. All right? All right, let's look at flushing and warmth now. Those are two symptoms that go with hypermagnesemia because magnesium makes you vasodilate. Magnesium makes you vasodilate, which is going to also make your blood pressure come down. Anytime you vasodilate, blood pressure is going to come down. That is why your teacher told you to administer that when you have somebody with PIH. Remember, when you have the PIH lady, pregnancy-induced hypertension, we gave mag sulfate because it vasodilated and brought their pressure down. But also magnesium acts like a what? Sedative, which will relax their muscles and decrease seizures in the PIH lady too. Well, we're going to talk more about that later. Now, let's look at the signs and symptoms in the center there. Anytime I have symptoms in the middle, they're applicable to both disorders that we're talking about on that page, okay? First of all, deep tendon reflexes. If you're sedated, are your DTRs going to increase or decrease? Decrease. What's your muscle tone going to be like? Weak, flaccid. Could I have an arrhythmia? Yes. Now drop down to the bottom of the page. Very bottom of the page. You see the hint? It says, if you want to get magnesium and calcium questions right, think muscles first. Think muscles first. Well, back to arrhythmias. Your heart is definitely a muscle, isn't it? Yeah, so you're going to have arrhythmias. LOC, is your level of consciousness going to increase or decrease? It's going to decrease because magnesium acts like a what? Sedative. What's going to happen to my pulse? Decrease. Respirations? Decrease, yes. Anytime you've got somebody on the drug, mag sulfate, you're always checking their respiratory rate, right? Always. Now then, let's look at our treatment for hypermagnesemia. Well, they might be put on the ventilator. Not everybody has to be put on the ventilator, but anytime the respiratory rate goes below 12, you're going to get put on the ventilator. Dialysis, because obviously my what aren't working? Kidneys aren't working, or I would have excreted the excess magnesium. And then calcium gluconate. I bet your teacher told you that calcium gluconate was the antidote for mag toxicity. Do you remember that? The antidote for mag toxicity? And I have the action written on your handout. Calcium gluconate. In the presence of magnesium, they inactivate each other. Okay? They inactivate each other. All right, now let's go back up to hypercalcemia. Hypercalcemia causes hyperparathyroidism. That's when you have too much PTH, capital PTH. Now, drop down to the bottom of the page and hang a left with me. Go to the box at the bottom of the page on the left. It says, when your serum calcium gets low, parathormone, PTH kicks in and pulls calcium from the bone and puts it in the blood. Therefore, the serum calcium goes up. Now, I want you to take just 15 seconds and read that little box to yourself and commit that to your memory. Okay. Do we all agree now that PTH makes serum calcium go up? Yeah, you got to know that. PTH makes serum calcium go up. So back up to the top of the page, hyperparathyroidism, too much PTH, so now I know why their serum calcium is too high, right? Now, thiazides, it is just a fact you have to know. They make you retain calcium. Make you retain calcium. In immobilization, You have to bear weight to keep calcium in the bone. So if you aren't bearing weight, y'all, like if you've got somebody on bed rest for a long period of time, the calcium's going to leave their bone and move into the blood. Therefore, the serum calcium just went up. All right, so therefore, if I'm hypercalcemic, what are my bones going to be like? Brittle. Think about it, y'all. All of that calcium in my blood didn't just magically appear. It had to have come from my bones. That's right. Now, kidney stones also can occur because the majority are made of calcium. Now, all of those signs and symptoms that we've already talked about in the middle are applicable to hypercalcemia because we've already said that calcium acts like a sedative. Now, let's look at our treatment. You got to get me to moving. When you get me to moving and bearing weight, where is that calcium going to go back to? Bone. Is that a good thing or a bad thing? That's a good thing. We want it to go back into the bone. Fluids are very important to flush out the calcium. Flush out calcium. Prevent stones. Also, it says on your handout, phosphosoda and fleet cinemas. Well, both of those have phosphorus. Now, don't get me wrong. The fleets can have lots of electrolytes, but I'm focusing on phosphorus for a reason here. Both have phosphorus. Calcium has an inverse relationship with phosphorus. So when you drive the phosphorus up, the calcium goes down. That's what we want to happen here. Steroids now may be given to the hypercalcemic patient. And here's a fact you need to know, and we're going to talk more about this tomorrow. Steroids decrease serum calcium. Steroids decrease serum calcium. And like I said, we're going to talk more about that tomorrow in the endocrine system. Now, what do we need to add to the diet? More phosphorus. Okay? More phosphorus because we're trying to drive the phosphorus up so the calcium will come down. Now, you may be thinking, well, what's got phosphorus in it? Well, egg yolks do. But really the easiest way to remember phosphorus-containing foods is to remember this. Anything with protein in it has got phosphorus in it. Anything with protein also has phosphorus. And eggs are a great source of protein, right? So therefore they'd be a great source of phosphorus. On the next thing, it says safety precautions. Yes, we're going to take safety precautions because do we have somebody here that is sedated? Yes. And you must have vitamin D, D as in dog, to use calcium. Now, where do we get vitamin D from? Sunshine. It lives in our skin all the time, but it's activated by the sun. And calcitonin decreases serum calcium. Decreases serum calcium by driving it back into the bones. Calcitonin decreases serum calcium by driving it back into the bone. So before we move on, if you could give calcitonin as a drug, and you can, what would it be good for treating? Osteoporosis, because you're driving the calcium back into the bones. That's right. All right, on the next page, let's look at hypomagnesemia and hypocalcemia. At the top of your page, write this down. Not enough sedative. Not enough sedative. Not enough sedative. Now, hypomagnesemia causes, first of all, diarrhea. We have lots of magnesium in the intestines, okay? Lots of magnesium in the intestines. So, if you've got somebody that's having a lot of diarrhea, they're losing a lot of magnesium. And then alcohol also suppresses ADH and it's hypertonic. But also think about this, too. Do alcoholics like to eat, y'all? No, they don't like to eat. They like to drink. And when you drink a lot of alcohol, do you retain or diurese? Don't act like you don't know. You diurese, right? Alcohol makes people diurese because it is hypertonic. So, and if we're diuresing a lot, we're losing magnesium because magnesium is excreted through the kidneys. That's right. Also, when you're suppressing ADH, you're diuresing, aren't you? Yeah, when you suppress ADH, you're diuresing. So again, you're losing magnesium. Now, look at hypocalcemia causes. Hypoparathyroidism, radical neck, or thyroidectomy. Out beside all three of those, you can write this down. Not enough PTH. Not enough PTH. Now, on the page before, we said that the normal action of PTH was to make your serum calcium go up. But now we don't have enough with these three conditions, so your serum calcium is going to go down. Does that make sense? Now, with hypoparathyroidism, you just aren't making enough PTH. Just not making enough. But with the other two, radical neck and thyroidectomy, that's when the surgeon, I bet your teachers told you this, the surgeon could accidentally do what? Remove a couple of your parathyroids. You've got 4 parathyroids, 4 of them. So with these procedures, they could accidentally remove a couple of your parathyroids. Well, think about that. If you don't have as many parathyroids as you used to, do you have as much parathormone? So naturally, the serum calcium is going to come down. Those some things you have to watch for. Again, there's your hint that we've already talked about. If you want to get magnesium and calcium questions right, think muscles first. So let's look at our signs and symptoms. Muscle tone. What's the muscle tone going to be like if you do not have enough sedative, y'all? Rigid and tight is what I always say. Rigid and tight. And could my patient have a seizure? Yes, that's what I'm scared of. You see, the muscles can get so rigid and tight, they could have a seizure. Stridor, laryngospasm, because my airway is a what? Smooth muscle. Smooth muscle. Positive chavostics. That's when you tap the cheek and it starts to twitch. Not normal. That shows hyperirritability. Hyperirritability. It shows tight muscles. And a positive trousseau is when you pump up the blood pressure cup and the hand starts to tremor. Not normal. I've only seen that happen one time. And it was a little lady that I was giving calcitonin shots to for her osteoporosis. Now, explain to the person sitting next to you why the calcitonin shot was causing a positive trousseau. Come on, figure it out. When I gave the shot, the calcium was being driven back into the bone, so the drug itself was making the serum calcium drop. So when I pumped up the blood pressure cuff, her hand started doing just like that. Well, at that point in time in my career, all I knew was, oh, look, her hand's waving at me. This is not normal, okay? You see, a lot of the way we learn in nursing is by looking back to what we did to people, right? That's right. Now, arrhythmias, because my heart is a what? Muscle. What's going to happen to my deep tendon reflexes? Increase or decrease? Increase. Remember, I'm hyper. I have hyperreflexia. And you know, the deep tendon reflexes are so important, especially when you're giving mag sulfate IV. Because when somebody's getting toxic on magnesium, the DTRs are the first to go. They'll go before your airway goes, okay? So that's why in your OB book, when you were studying mag sulfate and PIH, they showed this big old chart of how to check all the deep tendon reflexes. That's a priority assessment when you've got somebody on mag sulfate because it's the first to go. The reflexes will go before your airway will go. Mind changes. Well, on the page before, when we were talking about being sedated, we said the LOC was going down. Well, this person's waking up. They're wild. They may be psychotic. They may be depressed. I didn't say they were coherent. What I said was they have mind changes, okay? Everybody's different, but I know they're not going to sleep, right? Yeah. See, brain tissue's irritated when your magnesium's messed up. So their mind will change. Swallowing problems can occur because my esophagus is a what? Smooth muscle again. And anytime we have somebody who's having trouble swallowing, my number one concern is, come on, it starts with an A. Airway, aspiration. Now let's look at our treatment for hypomagnesemia. Treatment for hypomagnesemia. Well, give them some magnesium, right? That's what they need if they're low on that. But check what function before and during IV magnesium. Kidney. Priority assessment, y'all, because what's the only way you have to excrete the excess magnesium? Through the kidneys. Now, I'm going to give you a little scenario here, then I've got 4 answers on your handout. Just listen to me for a second. Let's pretend we've got somebody on IV mag sulfate. I'm going to show you how NCLEX works, okay? They're on IV mag sulfate, and you're doing your hourly outputs just like you know you're supposed to do. In this hour, you go in, and the urine output is 180, okay? I can't make a decision about my patient based on one number, right? I got to have serial readings. So I go in the next hour and do the urine output again, and I notice that it has decreased to 140, 180 to 140. Now, based on this data, are you worried or not worried right now? Ask the person sitting next to you if they're worried or not. Okay, now here we're going to vote. How many of you are worried? Raise your hand. How many of you are not worried? Raise your hand. Some of y'all didn't vote, okay? I'm watching you. Y'all, here's an NCLEX rule. There are no happy NCLEX questions. In every single NCLEX question, there is something to worry about. Or it won't be a question on NCLEX. So let me ask you again. How many of you are worried? Everybody better be raising their hand now. Now here's what some of you were saying. Okay, I'm worried, but I don't know what I'm worried about, right? That's the normal response, okay? But as long as I got you to worrying now, you one more steps toward passing the first time, okay? You've got to understand the core content of NCLEX, and I've already told you that the action of magnesium is what? That it acts like a sedative, and the only way I can excrete the excess from my body is through the kidneys, and my urine output in that scenario had done what? Decreased, so I'm retaining magnesium, which acts like a sedative, which could do what to my respiratory rate? Decrease it. Now some of y'all think, well, I'd have never thought of all that. Well, that's why you're taking the class, and so I can teach you how to think this way, okay? You don't start thinking NCLEX by hearing one scenario. But you've got to understand the core content first, then we've got to understand how the NCLEX people are thinking. I know that some of you thought about that urine output. You're like, oh, that sounds like a good urine output to me. I don't worry about urine output until it drops around 30 or 20 cc's per hour. Then I worry about it, right? No, on NCLEX, we are going to worry ahead of time. And if they give us data in a question, we're worried about it, okay? We are going to assume the worst. Why do you think they made that urine output look good? To see if you would do what? Worry or brush it off. They wanted to see if you'd go in the room and say, well, your urine output's pretty good. 140's pretty good. I'll be back in an hour to check it again. Okay? Bye-bye. No, we want to worry ahead of time. They want you to stay with them. There's a problem. So you've got 4 options there. Which one takes priority? There's A, B, C, and D. Ask your friend. Okay, let's vote. Everybody better vote. How many of you said call the doctor? Decrease the infusion. Stop the infusion. Reassess in 15 minutes. Okay, we've got to talk. First of all, there are times when call the doctor is going to be the answer. This isn't one of them, okay? Let me explain my rule for calling the doctor. If there's something you can do that will help the problem, you do that prior to calling the doctor. I said, if there's something you can do that will, here's the key words, help the problem, you do that prior to calling the doctor. Now, what did I say the key words were? Help the problem. So you got to identify what the problem is. Well, the problem is that the urine output has dropped and my patient's on mag sulfate, so they're retaining magnesium. And that's not good because it acts like a sedative. There's something I can do to help this patient. So that's why I'm not going to call the doctor right now. Many students across the country, the number one answer I get here is reassess in 15 minutes. Because you all were told in nursing school, assessment's the first phase of the nursing process. Y'all remember that? How many times have y'all said that, right? And even if it wasn't right on the test, you could argue about it long enough to get you 2 points, right, with the teacher? Okay. But let me explain to you the message you're sending here. You got to understand something. With every answer you select on NCLEX, you're sending a message to the NCLEX people about the kind of nurse you're going to be. Okay? They're sizing you up and trying to figure you out by the answer that you pick, and you've got one shot at telling them the right thing. If you picked reassess in 15 minutes, the message you're sending is this. Okay? You walk over to your patient and you say, okay, I know something's wrong with you because this is an NCLEX question. So I'm worried. I'll be back in 15 minutes, okay? Okay. Is that a good thing to do? Is that a good message to send? No. If you've got a question on NCLEX, it's a problem, and do the NCLEX people want you to delay treatment? Rule. Never pick an answer that delays treatment. It'll always be wrong. Never pick an answer that delays treatment. It will always be wrong. Now, another important concept that we need to go over here is this. In every single test question on NCLEX, there's going to be somebody in that test question. Okay? In fact, this person works at the testing center. You might have met this person already at nursing school. But when you pull up to the testing center, this person that I'm talking about is going to be standing in the front, and they're going to open the door for you and say, "Welcome to my testing center." Does anybody know who it is? The devil. The devil works at the testing center. And he's in every question tempting you. Now, y'all, when the devil is tempting you, does he tempt you with something that looks good or something that's ugly? It's got to look good, or how can you be tempted by it, right? Right. So that's why all 4 answers may look good to you. Well, that's the devil tempting you. Now, what does the devil want us to do to people? Good things? No, he wants us to do bad things. He either wants us to hurt them, kill them, or give them long-term residual damage. Now, are you going to get a license like that? No, so we've got to learn how to fight the NCLEX devil, okay? With reassess in 15 minutes, the devil was sitting up in the bed with the patient flipping the remote, okay? They were watching TV together, and you walk in the room, and you're like, okay, I know something's wrong because this is an NCLEX question. What does the devil say? Go on, girl, I'll watch her. It's just 15 minutes. What can happen in 15 minutes? And so you and your insecure self may leave the room. Okay, well, I'll be back. It's just 15 minutes. I'll be back, patient. And when you come back in 15 minutes, what color's your patient? Blue. I didn't have to go to nursing school to know something's wrong now, right? I mean, the maintenance man in the room is like, something's wrong in here, right? He didn't go to nursing school. You just let that patient keep on getting what for 15 more minutes? Magnesium. That's not nice. Now look at the answer. Decrease the infusion. With that one, the message you're sending to the NCLEX people is this. Okay, I'll do something. I'll slow it down a little bit. But the other message you're sending is this. I'm going to kill her slowly. I'm still going to kill her, just more slowly, because I want to watch the death process. I've read about it in the book. You see how devilish that is? That is not nice. You're not going to get a license like that. So what do the NCLEX people want us to do? Turn it off. Don't let them get any more magnesium. And then they want you to run, turn it off, and then run, go get somebody that knows more than you do. Only problem is when you go out there, it's your friend that graduated with you, right? And both of you have already failed boards once. Now you don't know what to do, okay? Now, seizure precautions. Absolutely, we're going to take seizure precautions. And what do you do if your patient begins to complain of flushing and sweating when you start IV magnesium? Stop it and go get somebody that knows more than I do. Now, here's what some of you were saying. But Marlene, that's going to happen. When you give magnesium to people, they're going to get all flushed and sweaty. Well, do the NCLEX people want you to give magnesium to somebody and now your patient's complaining to you? Do they want you to turn around and say, oh, girl, that's normal? Everybody does that. That's a red flag. When you're sitting there saying, that's normal, you better watch out. Here's my rule for NCLEX and drugs, okay? Unless you're just a pharmacology expert. If they give you a drug and they give you symptoms with it, something's wrong. So don't sit there and say, oh, well, that's going to happen. That's normal. It's on the handout. Because we did talk about it on the page before. That's bad. All right. Now, let's look at our treatment for hypocalcemia. Well, give them some vitamin D so they can use calcium. And Amphigel can be given. It's a phosphorus binding drug. Well, when you bind phosphorus, that makes it invisible. That's the way I think of it. It's invisible now. So naturally, my serum phosphorus just went down, which was sneaky, but it made my serum calcium go up. Is that a good thing or a bad thing here? That's what we want to happen. Also, IV calcium can be given. Okay? Now, always, when you're giving IV calcium, always make sure your patient is on a what? Heart monitor. Now, let's understand why. First of all, when you're giving IV calcium can decrease the rate, slow them down. But IV calcium can also widen your QRS complex. Can widen your QRS complex. And this is what I want to talk about for a second. All right, so you start giving your patient calcium, all right? And you see that you've already got a PQRS and T up there. Well, what did I just tell you? That it was going to do what? Slow down the rate, but it also could widen the QRS complex, okay? So, here we go. It just got a little bit wider there, didn't it? Okay, so, well, the book said it was going to get wider. Just give them some more. Oh, look. It just got wider. Just like the book said it was going to do. Give them some more. I can still see the PQRS and D, can't you? All right? But what's happening? Well, I kind of can see it there. Well, I didn't have to go to nursing school to know something's wrong when this happened because I've been watching ER, right? Right. I've thrown them into asystole because I've widened the QRS too much. You see, in the textbooks, y'all, they will say something like this. A certain degree of QRS widening is appropriate. Do they want you as a brand new nurse with 2 weeks of vast nursing knowledge to sit there and look at that and say, well, a certain degree of QRS widening is appropriate? Or do they want you to say, oh, shoot, it just got wider, don't give any more? That's what you're supposed to say. So that's why a lot of times things that we learn is normal can be life-threatening on NCLEX. All right, let's look at sodium now on the next page. Sodium. Your sodium level in your blood is totally dependent on how much water you have in your body. Circle water. This is the only electrolyte that cares about water. No other electrolyte can even be affected by water. Now, here's what people have been told in school. Sodium follows water. Water follows sodium. Not always. We've already talked about 2 times this morning when they forgot to follow each other. What was the name of those 2 diseases we talked about? SIADH and diabetes insipidus. They didn't follow each other, now did they? And they're not following each other here. If sodium and water always followed each other, we would never have hypernatremia and hypo. Now let's look at hypernatremia. That's the same thing as being dehydrated. And everybody in here has been dehydrated at some point. You had too much sodium, not enough water. All right? Causes hyperventilation. Because every time you exhale, do you lose water? Yeah, losing water. Heat stroke, you're losing water. And diabetes insipidus, what are you losing? Water, once again. Signs and symptoms: dry mouth, thirsty. And you're already dehydrated by the time you're thirsty. Now, in severe cases, you can have a swollen tongue. That's very unusual. But the reason I mention it here is that's just very specific for severe hypernatremia. But also, neuro changes. Now, you put a star by this one, because this is the one that will kill you. This is the one that takes priority. Anytime you see the word priority, you pick the killer answer. You see, your brain doesn't like it when sodium's messed up, and the neuro changes, y'all, are applicable for hypernatremia and hypo. Either one of them. You can die from nothing else but your sodium being messed up. But you probably already noticed in school that people don't look at the sodium that much. Everybody wants to know about the potassium, don't they? Sodium can kill you as well. Now let's look at our treatment for hypernatremia. Treatment, we're going to restrict sodium. Restrict sodium, and we're going to dilute the patient with IV fluids, because diluting makes serum sodium go down. Good. Daily weights in I&O are important because of the sentence out to the side. If you've got a sodium problem, you've got a fluid problem. Lab work. Well, check your lab work every day if they're drawing electrolytes. And feeding tube people tend to get dehydrated. Because, you know, it says on the can of Ensure or whatever the product is, total nutrition. Everything you need to live is in that can. All the protein, vitamins, and minerals. Yes, everything you need to live except the water. That's why we have to add water to our tube feedings many times, okay? Now, let's look at hyponatremia. The patient's too dilute. Too much water, not enough sodium. Causes: vomiting and sweating, and then drinking water. Only water I'm talking about. You're only replacing the water. You know, when you sweat a lot, you're not supposed to just drink water. You're supposed to drink Gatorade, right? To replace the electrolytes and the water that you're losing. If you're only drinking the water, you're diluting yourself. Sometimes you'll be working in the ER and you'll see somebody who brings their baby in and the baby's had vomiting and diarrhea, and you notice in the bottle there's a clear solution. You hope it's what? Pedialyte. But when you ask what it is, they may say water. And you may have a 1-month-old baby who's not flexed up anymore like this. You see, that's a neuro thing when they're not flexed. The baby's just laid out like that. Neuro, because they're so dilute, the brain has become affected, you see. Or you've got somebody of low socioeconomic class, and they might be trying to make their powder feedings go further for the bottle feedings, and it's diluting the baby. It's very important that they use the right ratio of powder formula to water when they're mixing that. Psychogenic polydipsia is another place when the patient becomes too diluted, because this is a patient that loves to drink what? Water, water, water. D5W, that's just sugar and water. We've all taken care of people before that have been getting D5W, 75 cc's per hour. That's all they're getting is sugar and water. They can get too dilute. And then also the disease SIADH, retaining too much what? Water. There's the neuro changes again. You may have heard about the cases of child abuse where the caregiver made the child drink a bunch of water, and then their brain swelled from ICP troubles and they died. That's what happened when the sodium gets messed up. Your brain doesn't like it when sodium is messed up. Treatment. Patient needs what? Sodium. Patient doesn't need water. Now, if having neuro problems, they're going to need some hypertonic saline. Now, from this point forward, anytime you see the word hypertonic, I want you to think packed with particles. That's on your handout. Packed with particles. And your next job is to figure out, okay, what's the particle? Well, if it's hypertonic saline, what's the particle? Sodium. So you're given a very concentrated form of sodium. Can this be dangerous? Yeah, because your brain doesn't like sudden shifts in the serum sodium. You got to be careful with it. Examples would be like 3 to 5% normal saline. All right, on the next page, we have potassium. Now, put a star by excreted by the kidneys. Kidneys not working well, the serum potassium will go up. Hyperkalemia causes kidney troubles. Well, that makes sense because of the sentence we just read. And aldactone. Aldactone makes you retain what? Potassium. Makes you retain potassium. Signs and symptoms now of hyperkalemia. Begins with muscle twitching, then proceeds to weakness, then flaccid paralysis, but also with potassium problems could we have a life-threatening arrhythmia? Yes, so put a star by that. That's your priority. That's the killer answer. Remember when it says priority, we're going to pick the most life-threatening answer. Treatment, dialysis, because my kidneys aren't working. That makes sense. Calcium gluconate to decrease arrhythmias. Decrease arrhythmias. Glucose and insulin. Insulin carries glucose and potassium into the cell. Glucose and potassium into the cell. You see, y'all, when you're giving insulin, it's going to carry, you already know about the blood sugar thing. It's carrying the sugar out of the vascular space into the cell. Therefore, my blood sugar just what? Dropped, okay? But we're talking about it under potassium for a reason. It'll do the same thing with potassium. It carries it out of the vascular space into the cell. So, anytime you give IV insulin, worry about hypoglycemia and hypokalemia. Hypoglycemia and hypokalemia. Now, the next drug on your handout is K-exolate. Circle the K in K-exolate. So you'll always think about hyperkalemia. That's why it is given. It exchanges sodium for potassium in the GI tract. And it says in the little square on your handout that sodium and potassium have an inverse relationship. Inverse relationship. So what you're doing with K-exolate is you're driving their sodium up in an effort to bring the potassium down. When you drive somebody's sodium up, could you make them dehydrated? Yeah, that's what I'm scared of with K-exolate is dehydration. So that's why we're pushing fluids. All right, let's look at hypokalemia now. Hypokalemia causes vomiting, NG suction, because it says in the little square that we have lots of potassium in our stomach. Diuretics and not eating. If you're not eating properly, then you aren't getting adequate potassium. Signs and symptoms, muscle cramps and weakness, and then life-threatening arrhythmia is also here. Treatment, give potassium. Give them some aldactone. If you give them aldactone, that's going to help them hold on to what? That's right, potassium, and get them to eat more potassium. Now drop down to the bottom middle where it says extras. Major problem with PO potassium is GI upset. GI upset, give with food. GI upset, give with food. Put a big star by the next sentence. Assess urine output before and during IV potassium. You better not ever start IV potassium if they don't have a good urine output. Could it kill them? Yeah, because the only way you have to excrete excrete potassium is through the kidneys, the urine output. Always put IV potassium on a pump. We want to be very careful with it. And if you mix your own infusion, you mix it well. And be sure and label the bag that, hey, this has got potassium in it. If you don't mix it really, really well, it can settle out in the bottom of the bag, and then your patient can get a bolus of potassium. Would that be a good thing or a bad thing? Bad. You never want a bolus of potassium, now do you? Never give IV potassium push. Instant death. Not going to get a license like that, okay? And is it going to burn during the infusion? Yeah, the greater the concentration, the more it burns. The greater the concentration, the more it burns. And infiltrates, for that matter. So you've got to be careful with it. And is it okay to add to a bag that's already up and running? No. Always get you a new bag and start over again. Now, I know what some of you were thinking, well, what if you just hung that bag of fluid an hour ago and it's still got 900 cc's left to count in it? I sure do hate to waste that. And so I'm just going to recalculate it. Because if he wanted 40 in a liter, 40 kcl in a liter, then I can figure up how much of that I would need to add to 900. Don't do that on NCLEX. Why? The NCLEX people know, they already know that it took some of us 3 times to pass the math test, right? And they would rather you just start over again and not take chances. All right, let's take a break.